The first conference I ever spoke at, I was at a big auditorium in England, and I was one of the afternoon speakers, so I was sitting way in the back watching one of the morning speakers, and she fainted twice at the podium. And I thought, okay, I was back there wheezing. And I thought, by the end of the day, if I just finish my talk and I'm still upright, I think I've won. So I was asked to talk about respiratory issues with the elderly, and I needed to scale that down a bit. So I narrowed it down to COPD and asthma, which still I think is a couple hours each. So what I'm going to try and focus on is mainly the management outlines or the standards that are put out for both of these diseases. I'm required to put a personal disclosure up. I have nothing interesting to confess to you. I have no financial interest in this, and I'm sure I won't be able to retire for a very long time because of the need for RTs. My primary objective for us today is to start out with a few laughs. And I don't know if you've ever heard of this group of CRNAs, nurse anesthetists, that call themselves the laryngospasms. And they have been performing and recording for quite some time. And so, does anybody remember Neil Sedaka's Breaking Up is Hard to Do?
Patience going down, do down, down. Patience going down, do down, down. Patience going down, do down, down. Waking up is hard to do. Don't take my time away from me. I'm trying to breathe, can't you see? Take it out and I'll turn you. 'Cause waking up is hard to do. I beg of you, one more try. I'm only 9 hours down to die. I put all my faith in you. 'Cause waking up is hard to do. They say that waking up is hard to do. Now I know that it's true. Don't say that this is the end. Instead of waking up, I think my decisions opened up again. I am inside a misery. Feels like my eyes are taken, I can't see. If I wake, I'm going to sit down. 'Cause waking up is hard to do. They say that waking up is hard to do. Now I know that it's true. Don't say that this is the end. Instead of waking up, I think my decisions opened up again. Now I'm awake, I can breathe and see. My bladder's full and I've got to pee. Now I think I'll throw up on you. Waking up is hard to do. Down, down. Patience going down, do down, down. Patience going down, do down, down. Waking up is hard to do.
Isn't that great? Okay, I have to have other objectives other than that too. Looking at asthma and COPD separately, what I'm going to concentrate on, like I said, is mainly the management standards. So we'll go over all of this that you'll find on, you can find at some good websites that are listed at the end of the presentation that you'll have on your zip drives. But I'll also go over what your favorite asthmatic won't tell you. The same objectives for COPD, except we'll also cover exacerbations because they're absolutely going to happen with COPDers, and what your favorite COPD patient won't tell you, which is usually either horrifying or entertaining or both. Under obstacles to care for the elderly, I'm sure that many of these obstacles are similar to the chronic diseases that you've already addressed at some of the other lectures. One of the things is that inhalers probably have oral meds beat hands down for difficulty in use. That's a real problem that we have. For patients with arthritis, they can't actuate some of the inhalers, or they can't even open the foil wrap on the tiotropium, the Spiriva inhalers. There is what we call a leverhaler. It's a little actuation device with a built-in spacer that can help patients with asthmatic actuate a puffer type inhaler. But that's the medication administration is a real issue. Under lack of knowledge of the disease, I wish that all the patients had access to the pulmonary rehab info that we would give them on pacing and oxygen use and how to take their medications. That would be wonderful. A very small percentage of, I think, COPDers ever get to actually go through pulmonary rehab. Under non-compliance, part of that is access to health care. Many patients would benefit from seeing a specialist, and yet a lot of communities don't have a pulmonologist or an allergy asthma specialist. Another thing under non-compliance, have any of you ever worked with a chronic lung patient that's a little bit focused on their disease? Have any of you worked with a COPDer who's not a little bit focused on their disease? So that's really an issue too. We'll come in and we'll say, you know, this something different might work. And they really are very into their regime and non-compliant as far as any changes. The physiological changes with the elderly also work against us when they have respiratory disease. There's a diminished response to hypoxia and hypercapnia in the brain to start with. And then there's a declined PaO2 with age that is normal. And they have an increased residual volume even before they become an emphysema patient. So that doesn't help. Looking at asthma prevalence, nearly 1 in 12 Americans are diagnosed with asthma. That's even higher in Montana. We're about 12% of Montana adults. The highest number there in the multiracial group, the 14.8%, is actually non-Caucasian children, and a lot of that is inner city. What's really disturbing is asthma rates increasing in the US for unknown reasons as of 2009. That was recently put out by the CDC, and they don't know what to attribute that to. Definition of asthma. This is the technical definition: chronic inflammatory disorder, episodic and reversible airflow. Reversible is our key component of that. Airway hyper-responsiveness and underlying inflammation. So it mentions inflammation twice. That's the key word for it here. I don't ever tell patients that definition because their eyes glaze over. What I tell them is asthma is your airways are hyperactive or hyperreactive. If you are exposed to a trigger the same as somebody next to you that doesn't have reactive airways, you're going to react and they're not. And there are 3 things that come out of that. There's bronchoconstriction on the outside of the airways, inflammation on the inside of the airways, and mucus production. Between the 3 of those, there's obstruction to airflow. And those 3 components are present in the COPDers also. We'll talk about that. So common asthma symptoms, you know, are wheezing, coughing, and shortness of breath. But I'd like you to appreciate the broad spectrum of the disease. An asthma patient can look like a debilitated wheezer, or it can look like a fully functional person that doesn't show any symptoms most of the time. Or it could be somebody who just has a chronic dry cough and that's the only thing that they show. That is one of the major symptoms of uncontrolled asthma, is just a chronic dry cough. This somewhat fuzzy slide shows the 3 components of asthma, with the bronchoconstriction on the right and the inflammation and the excess mucus production. And let's see if I can get my laser to work. Nope. Components of asthma care. These are put out by what we call an EPR3 guidelines. EPR3 stands for Expert Panel Review on Asthma, and it's the 3rd time that they've convened. This was in 2007. And they've put out excellent guidelines for staging the severity of asthma and treatment guidelines for the stable asthmatic and for the emergency room, how to go about diagnosing. It's really a very, very helpful guidelines. These are available on the internet. One of the things we're also going to look at is just a differential diagnosis so that we know that the patient has a correct diagnosis to start with. Asthma is often early onset. You know, many children have it. About a third of children outgrow it. The rest of them keep it as adults. Reversible, there's a family history component there. Children are most often to have asthma if their mother has it. Symptoms can vary. Very strong allergic component. We'll go over what COPD looks like different from asthma. CHF is going to have shortness of breath also, but they'll have a chest x-ray that shows engorged vasculature, and an asthmatic would not. They also have different pulmonary function tests, or PFTs. Pulmonary embolism, there would be a sudden onset of profound hypoxemia instead of just lower oxygen sats with the COPDer. Tumors can show up on a pulmonary function test and cause shortness of breath. And GERD actually can trigger asthma, or it can mimic asthma. So anytime a patient tells me that they're short of breath just when they lay down or they wake up short of breath, we look at the whole orthopnea picture there and see why that might be and if they might have GERD. Cough secondary to drugs, ACE inhibitors are notorious for promoting a dry chronic cough. In vocal cord dysfunction, this is the patient who says, there are times I can't breathe at all and my inhaler doesn't do any good. To me, that's a red flag to question them further. If what they'll talk about is there are times they can't move air in or out and the inhalers don't help, and that's probably the cord shutting down. One of the main diagnostic tools that we have in asthma is a pulmonary function test. Of course, this is in addition to a thorough H&P. The PFTs are going to show reversible airflow obstruction, but at any time when an asthmatic has a normal PFT, that doesn't mean that they don't have asthma. That just means at that particular date and time, their lung function is normal. What happens is if they have a normal PFT and the physician still wants to do further testing and see if they have asthma, we'll do a bronchial challenge test. And what that means is under very careful conditions with the physician knowing that we're doing the test at the time, we actually try and stimulate some bronchospasm. We have the patients breathe either histamines or methacholine in very diluted concentrations, and we do serial testing of the PFTs. And a person without hyperreactive airways won't react to inhaling these, and a person with reactive airways would. We can also do an exercise challenge test, pre and post PFTs, to see if that's it. A chest x-ray is usually normal in an asthmatic. That's not going to help unless they're really in a severe exacerbation, and it would show some airway trapping. So asthma education, of course, is huge. We have to cover the basics with them. Every single time we meet with an asthmatic, we need to go over the education process again. The peak expiratory flow and the AAP over there on the side, the peak expiratory flow measurement is very helpful because it's an objective measurement. And as an asthmatic, I've been very humbled by my disease at times because most of the time I have no symptoms. I don't have to take controller meds. And yet I have certainly underestimated how it can flare up and rear its ugly head at times. And the peak flow is objective. So if you're in denial that it's really not that bad, the peak flow will tell you where you're really at. If you're the parent of an asthmatic, it can tell you, are they really too sick to go to school? Or do they want to go to school, they really need to stay home? Yes?
I'm sorry, what do you mean by peak flow?
Peak flow, thank you for asking. I guess I'm just assuming. It's a little device that's going to measure how fast you can blow your air out. Okay? So normal ranges for men are usually about 600 liters per minute, but we're only measuring it out for a second or two, and women is about 500. If we have a patient come into ER and they're, say, below 200, we know they're really clamped down at the time. But you take a deep breath in, lips tight around the mouthpiece, and blast it out as hard and fast as possible, and it'll move a little lever there and show you how fast that peak flow is. So like I said, the great thing about a peak flow measurement is it's objective. And the AAP is an asthma action plan.